Thank you very much. So thank you, first of all, for the honor of this invitation, and I have to apologize for this delay. And it's an honor to share this again with many of my Greek friends in Greece, which we had seen in the EANS and also in the EANO. And that's what my subject is, the current EANO guideline on diagnosis and management for gliomas, and especially the take-home messages for the neurosurgeon. So these are my disclosures. They are not related to the talk. So actually the WHO classification from 2016 switched from a in former times based more or less histological diagnosis to what they call integrated diagnosis. So it's a layered diagnosis, and the first layer is immunohistochemistry as we knew it in the past, so the mirror image of the tumor under the microscope. But then two new kits turned up and around the block. One is the mutation of the IDH1 or IDH2 gene, and the other is the co-deletion of chromosomal material on 1p and 19q. And both of them had been shown to be real prognosticators, not only predictors for therapy, but prognosticators in therapy. And as all of you recall, the WHO grading actually came up with the aim, when it was founded, to dissect the tumors according to their clinical course. So the basis of all WHO classification systems in the past had been the clinical course under current therapy. So once IDH1 mutation and co-deletion 1p19q turned up to be real prognosticators for the clinical course of these tumors, of the gliomas, they were consequently integrated into the diagnostic scheme in 2016's revised version. And this turns up now with an integrated diagnosis, which means you have immunohistochemistry, you have the question whether or not it's IDH1 mutated tumor, and you have to see whether or not co-deletion of 1p19q occurs. The co-deletion 1p19q number 1 is only restricted to oligodendrogliomas, and number 2, it only occurs in IDH1 mutated tumors. This has two consequences. Number 1, there is no such a thing like an oligoastrocytoma. This is gone. Either you have a co-deletion, then it's an oligo, or you have a non-co-deleted tumor, then it's an astro or something else. Number 2, since co-deletion is more expensive to test, but it only occurs in IDH1 mutated tumors, the sequence is that you first check for IDH1 mutation. If it's an IDH1 non-mutated or wild-type tumor, then there's no need to test for co-deletion because it will never occur. So in other words, you do first the IDH1 mutation analysis, and if the tumor has an IDH1 mutation, then you go for co-deletion testing. And that turned up that you have astrocytomas, oligodendrogliomas, and then different type of, at that time, astrocytomas, IDH1 wild type or glioblastoma. And another kit turned up, and that was the diffuse midline glioma with a special mutation H3K27M. These were restricted only to midline tumors, which is brainstem, thalamus, basal ganglia, but also the spinal cord. And this is a very small fraction of tumor, obviously with a complete different clinical course. So a number of genes turned out in the later phases, which were also related to the fate of patients with a glioma or glioneural tumor. And this is some very important sentence. Molecular data must always be interpreted in the appropriate clinical and histopathology context. So in other words, large cohort studies were necessary to check whether or not these different molecular alterations really do make a difference in patients' fate. And that turned up to the EANO guideline, which was published actually in 2020, which is now being printed 2021, with a group from the EANO, European Association of Neuro-Oncology, to be the current guideline now. And the important thing, this is with the dark here, it's open access. So you can download it without paying for it. And this is now how the scheme looks like in actually 4 years after the publication of the revised WHO version. Instead of IDH1 and co-deletion 1p19q, you have now 7 different gene signatures here, which discriminate different type of tumors. And the most important thing is that the first issue is whether the tumor is IDH1 mutant or wild type. So if you have the IDH1 mutant tumor, the next thing to look whether it's co-deleted 1p19q. If these two things are answered by yes, then you have a true oligodendroglioma. And it can be graded as 2 or 3. And actually, and we come to this later, the difference between 2 and 3 does not matter so much right now, and most likely will be even more or less deleted in the next WHO classification. So all tumors grade 2 and 3 will now always be lumped together into studies. So they will no longer be separate grade 2 or grade 3 studies. WHO grade 2 and 3 is similar, the same in the oligos. If you have the IDH1 mutant tumor without co-deletion, so 1p19q is intact, then you talk about astrocytomas. And now astrocytomas are no longer grade 2 and 3, but also grade 4. And this is relevant even in cases where you see necrosis. So that's a major difference to the former world where necrosis was linked to glioblastoma. And then sometimes you had something like a IDH mutant glioblastoma. So the impact of necrosis in the histological under the microscope is far less important than the mutation. So if you have an IDH1 mutant tumor, it's no longer a glioblastoma. It's an IDH1 mutant astrocytoma, WHO grade 4 in the presence of necrosis. So this is the real one of the very profound new differences showing the power of IDH1 mutation in clinical terms and separates the good from the bad, which the bad is the wild type tumor. The wild type tumor, regardless what else comes after, is always a glioblastoma, period. So you have IDH1 wild type tumor, either with or without TERT mutation, with or without necrosis. This is glioblastoma, always grade 4 WHO grade. Then you have diffuse hemispheric glioma, which is a very, very small cohort. We are just in the German glioma network, and others we are looking into whether G34 mutants do differently to these guys. And then we have, as I said already, we have the midline tumor. So the midline tumor is identified by its location and this typical burden of mutation with the H3K27M mutation. And obviously these tumors do worse, and we have now a series of spinal cord tumors being analyzed, which are now going to be published, where also this type of mutation separates the good from the bad spinal cord tumors. So the important thing is, if you have a tumor like this, if you have this is your MRI image, no contrast enhancement, and you have another one also no contrast enhancement, the typical T2 alterations here like there, and then you do just a stain for IDH1 mutation, you see this is a mutant and this is a wild type tumor, and this is a grade 2, and this is a glioblastoma. So they look completely similarly in the image, one different gene and completely different diagnosis. So don't judge a book by its cover. Don't make glioma diagnosis just by imaging. You have to have molecular information in order to make a decision about the therapy. So how about the therapy now? This is the guideline of the paper with the therapy part. If you have a patient with an IDH mutant tumor and you go now for biopsy or resection, followed by early post-op MRI, this is what we should aim at. If we don't get access to the MRI, you can do CT, but you should ask your neuroradiologist to have the MRI within the first 2 days after surgery. It's only for the surgical part, not for the biopsy part. And then you go for the therapy. And it says that all these patients, if you have a oligo patient, you do PC therapy. Also, this is a discussion which we have now. In the grade 2, you may do wait and see after complete resection, but in the grade 3, which is yet to be defined, you have to do radiotherapy and then followed by chemotherapy. Is it important, the grade 3? To be honest, yes, it is not the single answer to the question. The most important thing is the patient's other way biometrical data. So older patients above age of 14, they have a less favorable prognosis. If they have neurological deficits, have a less favorable prognosis. And also if they have some residual tumor, all these patients come into this category of high-risk patients, and they should get radiotherapy and then chemotherapy. So even if you have a grade 2 with age over 40, neurological deficits or residual tumor, you will go for this. If you have a grade 3 without any tumor burden and being a young person, you may consider wait and see only. So if we talk now about PCV, the books still say PCV, but we have now considerable quality of data showing that the vincristine does not any benefit to this therapy, but a lot of side effects, especially polyneuropathy. So the rate of adverse events is 4 times higher if you add vincristine to procarbazine and CCNU. So just by giving PC alone, you're equally effective to PCV, but with much less toxicity. So we will end up in the future by PC only for the oligos. If we now go for the astrocytomas, the mutant one, as I told you, and WHO grade 2, again, wait and see if it's a favorable prognostic patient group, younger age, no tumor burden, or very, very little remnant. Then you may do wait and see, or else you go again for radiotherapy, and then again PC. PC seems to be more effective than temozolomide in these patients. So if you're talking about low-grade astrocytomas, you will also add PC as radiochemotherapy. In the high-risk cohort, again, older age, residual tumor, you have to do radiotherapy followed by chemotherapy. And there you can either choose temozolomide or PC. This is logically a little bit incongruent. So I think that many of the patients now will also receive PC in this setting. In the glioblastoma world, it's different. There you have temozolomide and chemoradiotherapy block after the radiation. So this is the typical STUB protocol, as all of you know. And if you have the unfavorable prognostic group, which is the older group, then the MGMT promoter comes into play. In the lower age group, this is not so much important. But in the older patients, MGMT makes a difference. These were the data where you see that MGMT methylated patients with temozolomide only did much better than the same cohort without MGMT methylation. But even the radiotherapy group with methylation did a little bit better, when they were irradiated than without irradiation. However, these differences were very small, so people then went to the suggestion that radiotherapy in this unfavorable prognostic group with a non-methylated MGMT promoter should receive it hypofractionated, which means it's a shorter period of treatment, and they get the same biological dose compared to the standard fractionated theme. And those old patients with a promoter, methylation of MGMT promoter, they should all see temozolomide, and you can defer radiation therapy and they will still end up in this green curve here. How about patients with an unfavorable prognostic factor? So they are non-methylated and they have a bad Karnofsky. These patients, as Stefan Grau already mentioned for the patients with brain metastasis, here the Karnofsky is the key player, also putting these patients into a group which should undergo radiotherapy only in a hypofractionated way. So if you're talking about brain tumors in the newly diagnosed setting, we can either do the resection or the biopsy and then get the molecular markers. And as Stefan Grau already mentioned for the metastases, the same is true for the gliomas. Once you have a recurrent tumor, you cannot be sure that the molecular profile is completely the same. And this is especially important when you talk about targeted therapies. You have to answer the question, is the target still there? And to answer this question, you have to do another surgery or another biopsy. This is not necessary for IDH1 mutation because we know that this is a very early lesion which will be maintained throughout the disease course. Also, co-deletion will never change, MGMT methylation does not change, and amplification of the EGFR receptor does not change. But, for instance, expression of the EGFR receptor variant 3 does change significantly. And that was one of the major mistakes in younger age study concepts, that one large multi-center study did rindopepimut therapy for patients in the recurrent setting, relying on the basis of the data of the newly diagnosed tumor. And afterwards, it showed that these expression of the receptor variant 3 changes dramatically. So patients without these expression were treated with rindopepimut and therefore did not respond. So in newer times, whenever we talk about recurrent tumor, then we have to do a rebiopsy or resurgery. And also when we treat patients with temodal chemotherapy, we know that the mutational load of the recurrent tumor is much, much higher than in the primary setting. So just by adding temozolomide to the therapy, we push the tumor into a mutational burden, which is much, much higher, 10 to 500 times higher than the primary tumor. And with that word of caution, I would like to thank you for your attention and apologize for my delay.